Welcome back to ERMP and Beyond, your go-to channel for engaging clinical case discussions. Whether you're a seasoned healthcare professional or an eager learner, I have got you covered. In this dynamic community, I delve into real-world cases, dissecting diagnoses, treatment strategies, and the art of medical decision-making. Expect evidence-based insights and pearls of wisdom from the channel. So, grab your stethoscope, adjust your white coat, and join us as we explore the fascinating world of medicine, one case at a time. Remember, curiosity fuels growth, and together, we'll go beyond textbooks and into the heart of clinical practice. Let's discuss today's case. Case number 17. A 60-year-old male patient is kept at the emergency room with ST segment elevated anteroseptal myocardial infarction of 6 hours duration. While waiting for ICU admission, he suddenly passed away. What is the most likely cause for his death? A. Ventricular free wall rupture. B. Ventricular fibrillation. C. Thromboembolization. D. Third-degree block. Try this in 25 seconds. I will back soon. Acute anteroseptal myocardial infarction is caused by occlusion of the left anterior descending artery, which primarily supplies the anterior wall and anterior two-thirds of interventricular septum of the heart. On an ECG, this is characterized by ST segment elevation with subsequent Q wave formation limited to precordial leads V1, V2, V3, or V4, which are the leads placed across the chest that directly view the affected area of the heart. These changes may be accompanied by reciprocal ST depression in the inferior leads, particularly leads 3 and AVF, which are on the opposite side of the heart. The magnitude of reciprocal change in the inferior leads is determined by the magnitude of ST elevation in leads 1 and AVL, as these leads are electrically opposite to leads 3 and AVF. In terms of clinical relevance, an anterior ST elevation myocardial infarction carries a poorer prognosis compared to other infarct locations due to the larger area of myocardium affected. Patients with anterior MI may experience higher incidences of in-hospital mortality, total mortality, heart failure, significant ventricular ectopic activity, and a lower ejection fraction upon admission. An anteroseptal acute myocardial infarction can lead to a cascade of complications that may affect the mechanical, electrical, and structural integrity of the heart. Acute MI results in the loss of functioning left and right ventricular myocardium. As the amount of healthy myocardium decreases, there is a progressive fall in the left ventricular ejection fraction. Cardiogenic shock may be seen when there is severe left ventricular dysfunction, rupture of the left ventricular free wall, rupture of the interventricular septum, and acute mitral regurgitation are the 3 mechanical complications of acute MI. These potentially lethal complications may occur with large MIs or with lesser degrees of ventricular dysfunction if the location of the infarct is critically placed. They are grouped together, as they have rupture or tearing of necrotic myocardium as part of their underlying pathophysiology. They often lead to cardiogenic shock. The true incidence of the 3 mechanical complications may differ from reported incidence due to underreporting, miscoding, or variation in the population studied. Reperfusion therapy has lowered the incidence of these mechanical complications. Mechanical complications are associated with high in-hospital mortality even if timely surgical or interventional repair is performed. In addition to the significant mortality, rates of cardiogenic shock, acute kidney injury, hemodialysis, and respiratory complications are higher in those with mechanical complications than in those without. Acute or subacute myocardial rupture is a serious and often lethal complication of ST elevation myocardial infarction. Rupture of the free wall of the infarcted ventricle is a relatively common finding in patients dying with an acute myocardial infarction. Several large studies have found cardiac rupture in 14 to 26% of such patients. The clinical presentation of myocardial rupture is variable. Left ventricular free wall rupture often occurs within the first 5 days after MI in about 1/2 of cases and within 2 weeks in over 90%. This time is the point during the healing process in which the infarcted myocardium is softest and most prone to rupture. Rupture can present as sudden death in an undetected or silent MI. In patients with known MI, complete or incomplete subacute rupture can occur. The mechanical complications of MI are associated with high mortality rates ranging from 25 to 80%. Complete rupture of the left ventricular free wall usually leads to hemopericardium and death from cardiac tamponade. The presence of rupture is first suggested by the development of sudden profound right heart failure and shock, often progressing rapidly to pulseless electrical activity, electromechanical dissociation, and death. The incomplete or subacute rupture of the left ventricular free wall can occur when organized thrombus and the pericardium seal the ventricular perforation. This condition can progress to one of the 4 outcomes. It may frankly rupture with resultant cardiac tamponade and hemodynamic compromise. It may form of a false aneurysm walled off by pericardial tissue. It may communicate with the left ventricle through the perforation, or it may form a left ventricular diverticulum. Incomplete rupture may be manifested clinically by persistent or recurrent chest pain, particularly pericardial pain, nausea, restlessness and agitation, abrupt, transient hypotension, and electrocardiographic features of localized or regional pericarditis. The diagnosis of free wall rupture is based on clinical and echocardiographic signs of pericardial tamponade. The echocardiogram typically shows pericardial effusion with evidence of chamber compression and may also be able to show the rupture itself. Emergency pericardiocentesis, when performed in a patient with acute cardiogenic shock and suspected free wall rupture, may confirm the diagnosis. Survival depends primarily upon the early recognition of myocardial rupture and provision of immediate therapy. In patients with suspected or diagnosed free wall rupture, emergency pericardiocentesis is indicated if fluid is visualized. If the patient stabilizes and bleeding stops, a conservative approach might be justified in selected cases. However, immediate cardiac surgery should be considered. Many patients do not survive the acute phase because of the development of immediate cardiogenic shock and pulseless electrical activity. Initial medical therapy aimed at hemodynamic stabilization should be instituted. This usually includes fluids, inotropic support, and vasopressors. Left ventricular thrombus is most often seen in patients with large anterior ST elevation myocardial infarction with anteroapical aneurysm formation. In most cases, these infarcts occur in the distribution of the left anterior descending coronary artery. These anteroapical infarcts have large areas of poorly contracting left ventricular muscle. Adjacent intracavitary blood movement is sluggish compared with normal areas. This relative stasis of blood is thought to increase the risk of thrombus formation. Many, but not all, of these patients will have an LV apical aneurysm with akinesis or dyskinesis. In most cases, thrombus is located within or adjacent to the left ventricular apex but can also occur with large inferolateral infarction. Contact of blood with the fibrous tissue in the aneurysm rather than normal endocardium is also thought to trigger clot formation. Based on the pathophysiology of the development of left ventricular thrombus, 3 clinical risk factors have been recognized. These 3 factors are more potent risk predictors in patients who do not undergo reperfusion than in those who do. The first risk factor is anterior ST elevation myocardial infarction by electrocardiographic criteria. The second is left anterior descending coronary artery infarct, especially proximal left anterior descending coronary artery infarct as determined by coronary angiography. The third is presence of large infarction defined as a left ventricular ejection fraction less than 30%. Importantly, most of these patients will have an left ventricular aneurysm. And the last risk factor is delay between onset of symptoms and reperfusion more than 4 to 6 hours due to the increased risk for an left ventricular aneurysm due to more extensive infarction and systolic dysfunction. The incidence of left ventricular thrombus has decreased as the frequency of primary reperfusion with either fibrinolysis or primary percutaneous coronary intervention has increased. Most patients with acute ST elevation myocardial infarction should undergo non-contrast transthoracic echocardiography to assess left ventricular function before discharge with specific evaluation of apical function, presence of aneurysm, and the presence of an left ventricular thrombus. In most patients with transthoracic echocardiographic thrombus, the diagnosis will be made using transthoracic echocardiography. When screening for transthoracic echocardiographic thrombus, particular attention should be paid to the left ventricular apex, or for any aneurysm or dyskinetic segment. In addition to reporting the presence of an aneurysm and wall motion in that region, the presence or absence of thrombus should be noted. Transthoracic echocardiographic characteristics of left ventricular thrombus are a mural or pedunculated echo density, often of similar acoustic properties to normal myocardium. The risk of embolization is similar to that of a clot within the arterial circulation in other locations. The natural history of left ventricular thrombi includes complete resolution and endothelialization. Prior to one of these endpoints, embolization may occur. The risk of embolization in patients with a documented left ventricular thrombus who are not treated with anticoagulant therapy has been reported to be between 10 and 15%. Anticoagulant therapy should be started early after myocardial infarction and continued for at least 3 months to lower the risk of thrombus development, growth, and embolization in patients with documented left ventricular thrombus or those at high risk. Most embolic events occur within the initial 10 days post-acute infarction, but the risk of embolization may continue for 3 to 4 months. The manifestations of systemic embolism often include strokes, although patients may also encounter limb ischemia, renal infarction, and mesenteric ischemia. Acute anteroseptal myocardial infarction can lead to various electrical complications due to the disruption of the myocardial tissue and its electrical pathways. These complications include arrhythmias such as ventricular fibrillation and tachycardia, which are immediate life-threatening conditions that can lead to sudden cardiac death if not promptly treated. Other electrical disturbances may involve conduction pathways, resulting in atrioventricular block or bundle branch block. The ischemia or necrosis of the myocardium can also affect the SA node or the AV node, leading to sinus bradycardia or complete heart block. The primary mechanism behind arrhythmias in acute MI is re-entry, which arises from the electrical irregularities within the ischemic myocardium. Arrhythmias related to reperfusion occur due to the removal of various ions such as potassium, lactate, and metabolic substances which have accumulated in the ischemic area. These arrhythmias result in unfavorable hemodynamic effects, particularly in patients with left ventricular dysfunction, as they exhibit a relatively consistent stroke volume and depend on variations in heart rate to adjust cardiac output. Prior to the establishment of coronary care units, primary ventricular arrhythmias were the primary cause of mortality in individuals experiencing acute MI. Ventricular fibrillation is the most frequent mechanism of sudden cardiac death. It is a rapid, disorganized ventricular arrhythmia, resulting in no uniform ventricular contraction, no cardiac output, and no recordable blood pressure. The electrocardiogram in ventricular fibrillation shows rapid, 300 to 400 beats per minute, irregular, shapeless QRST undulations of variable amplitude, morphology, and interval. Over time, these waveforms decrease in amplitude. Ultimately, asystole occurs. Ventricular fibrillation typically occurs early in the course of a myocardial infarction, often within the first 24 hours, and is a leading cause of sudden cardiac death. The timing of ventricular fibrillation can be immediate, early, or late, with the majority of cases presenting within the first 48 hours post-infarction. Ventricular fibrillation is presumably a manifestation of ischemia and is associated with lack of perfusion via the infarct-related artery. Primary ventricular fibrillation refers to a fibrillation that occurs early, usually within 48 hours post-myocardial infarction, and is not associated with recurrent ischemia or heart failure. On the other hand, non-primary ventricular fibrillation refers to all other episodes. Ventricular fibrillation is more common in patients with myocardial infarctions that are complicated by heart failure or recurrent ischemia. The occurrence of ventricular fibrillation among patients with an acute MI, if occurring within the first 48 hours, is associated with an increase in early mortality, such as in-hospital mortality, but little or no increase in mortality at 1 to 2 years among patients who survive to hospital discharge. Ventricular fibrillation is almost universally lethal if not treated, with very few spontaneous reversions to sinus rhythm. Defibrillation is the definitive therapy for ventricular fibrillation. If available, a biphasic waveform defibrillator is preferable since the success rate for defibrillation is higher than with monophasic waveforms. Third-degree heart block, also known as complete heart block, is the most severe form of atrioventricular block and represents a complete interruption of electrical conduction between the atria and ventricles. This condition can be transient or permanent. In terms of timing of occurrence, it is more likely to occur later than ventricular fibrillation, sometimes delayed until the third hospital day or beyond. It is often associated with inferior wall myocardial infarction and may resolve within 2 weeks. However, when associated with an anteroseptal MI, it indicates extensive damage to the conduction system and carries a higher risk of progression to permanent heart block. The mortality rate for third-degree heart block after MI is significant, with in-hospital mortality rates reported around 17.9% for those with the condition compared to 3.6% for those without. This figure summarizes the acute and long-term complications of acute myocardial infarction. Ventricular tachycardia and ventricular fibrillation may occur any time after the coronary artery is occluded. These arrhythmias, which are due to ischemia, are particularly common during the first few hours after artery occlusion. They cause the vast majority of deaths in the acute phase. The risk then rapidly abates within 6 hours. However, myocardial infarction, particularly if extensive and in presence of heart failure, may result in chronic remodeling of the myocardium. Such remodeling can cause ventricular tachycardia and ventricular fibrillation. The most common mechanical complication of acute ST segment elevation MI, and myocardial infarction in general, is papillary muscle rupture. Wall rupture, septum or left ventricular free wall, is less common. Ischemic bradyarrhythmia, bradycardia, is also common, especially with inferior infarctions. Therefore, the most likely cause of death for this patient with an ST segment elevated anteroseptal myocardial infarction, who suddenly passed away within 6 hours of the infarction, is ventricular fibrillation. Thank you for watching. Please like, comment and subscribe.